I want to introduce the next speaker. He's from France. He's a big friend of me and of all neurosurgeons of all Europe and for the world. Joseph Cristini. He's one of the founders of the very big society of all spinal endoscopic surgeon from full Europe. The name of this society is YESUP. YESUP organize every year a very big conference, which include the master class, which include live surgery, and also the presentations. That's why I want to introduce him. Joseph, do you hear me?
Yeah.
Joseph, hello, nice to see you.
Hello, Yuri, and thanks a lot, and I apologize to not to be here with you.
Okay, it's not a problem, but now you with me, and you with all our participants, with all our faculties, we want to thanks for your attending here. That's why, do you ready to start?
Yeah, ready.
Okay, let's go.
Can you see my screen?
Yes.
Okay. Let's go. Okay. Hello, everybody, and apologize not to be here with you. Thanks a lot to Yuri. Very lucky, I think, for Ukraine to have a guy like this. For us, it's a very, very big surgeon in endoscopy, a very big visionary human. I will speak about cervical spondylotic myelopathy with a circumferential approach. And first, I will just introduce the two techniques we can use. One of them is just laminotomy, removing the spinal process and going to the contralateral approach. And the other one is like an over-the-top technique, and you can just keep the contralateral lamina, and it's a technique we use in Marseille. Just this topic is for right-handed surgeon because we wanted to standardize the technique, and we always stay at the left side of the patient. At the beginning, the most important is to do the preoperative planning, but everybody knows that, and to decide if you see at the left part, if you go at the right part, if you do an interlaminar approach or another approach, and the distance between the incisions. But I think you saw that during all the conference. Some just details. We use a carbonate rest with a proclive at 20 degrees. The blood pressure is always under 100. We always use colorization. The water pressure with the arthro pump, it's between 15 and 20. And we always put adrenaline in the two first saline bags. And we always use tranexamic acid during the surgery and the day after. The installation is the same, the same we can use classically for all our cervical posterior surgery with just a carbonate rest with a column, but you saw that, and it's a simple installation. We stay always at the left side, and you always see the same orientation on the screen, and the orientation is on your left, the cranial part, on your right, the caudal part, and in front of you, the medial part, and it's always the same orientation when you operate. And you will see what kind of vision you can have. Sorry, it's accelerated surgery, but you can use an aggressive burr, and after you can use a diamonded burr to reduce the thin of the bone, and you can after that just remove all the bone, and you can obtain 75% of decompression of your spinal cord. We will begin by a controversy case. It's a 59 years old man, a sport trainer with a proprioceptive disorder and a pyramidal irritation. And as you can see on the image, we can see on the CT scan an OPLL. And it was the first challenge. And we decided to purpose him corporectomy, but he's a sport trainer, and he decided to refuse. And it was our first challenge, and we decided to go by an anterior approach and a posterior approach. But by an anterior approach, we could just do 2 ACDF, and by a posterior approach, you can decompress 2.5 levels with the same incisions. This is the MRI just the day after surgery. This is the CT scan 2 days after the first surgeries, because we always operate the patient 2 days after. And this is the MRI at 6 months, and this is the MRI at 2 years. This is maybe one of the most controversial cases, but we decided after this case to have a reflection to avoid this kind of case, because sometimes you have a lot of schools, an anterior school, a posterior school, and you can find at your consultation a lot of patients who had a big laminectomy with a kyphosis. And we decided to have a small algorithm and a small theory. For a multi-level myelopathy like this, we would like to limit the number of ICDF by not more than 2. We would like to avoid the sacrifice of the muscles and to avoid the cervical kyphosis. For that, we use the UBE technique. With 2 incisions, you can remove 2 laminas, and if you remove 2 laminas, you can remove 3 yellow ligaments, and for that reason, you can decompress 2.5 levels in cervical. But if you are more than 3 levels, you can have another approach and an anterior approach. And if we want to avoid the number of RCDF, we decided to just do 2 levels and not more. And with this theory, you can do 2 by anterior approach, 2 by posterior approach, and for that you can remove almost 4 levels, but sometimes more. And the most important after is to decide if you begin by a posterior or an anterior, and which level you do by the posterior approach and which level you can do by an anterior approach. This is one of the same video you saw first, and you can see we are in the contralateral part under the lamina, and you do the same, and you can always obtain a good decompression. In the literature, you have a lot of algorithms speaking about the OPLL and the key line, and you can find that in Asia and especially in Japan. And sometimes it's very difficult to understand all these algorithms because we have all very fast lives, and in constitution it's difficult to have a reflection with this kind of algorithm. And we decided to check all the algorithms in the literature. Sorry, I will be quick on these different articles, but we would like to simplify the algorithm. And for that reason, we did another algorithm. The other algorithm is just for the multi-level cervical approaches for more than 3 levels. And we decided to check the K line. If you have a K line positive, you can begin by an anterior approach and after a posterior approach. And if you have a negative K line, you can begin by a posterior approach by UBE and after that an anterior approach. This is a very simplified algorithm, but yes, we can improve this kind of algorithm. Be careful because you have some specification, and sometimes with young people and with discal calcification, because you can have some white cord syndrome with the spinal cord with the young people. And we can see an example. It's a 73 years old woman, retired, with she's very active and dynamic, but she had a right upper limb paralysis with this kind of MRI, but we always ask for a CT scan, and you can see the calcification of the disc. And we decided to begin by a posterior approach, the MRI just the day after, and after an anterior approach, and after that skiers 2 months after, and the results 6 months after with the MRI before and after. And you can do for all the case you can meet, but sometimes you can just do a posterior approach, just an anterior, but you know, if you do just a posterior, sometimes you have some foraminal stenosis and the decompression is not enough for the nerve, but yes, for the spinal cord. And for that reason, we always ask for a CT scan. Sometimes you can be disappointed by your decompression, and you can do a circumferential approach to obtain this kind of result at 6 months. This is another case. This is a general practitioner who came to see me for a walking disorder, but after the clinic exam, I decided to ask for a cervical MRI. Because I was not very convinced by all the clinic with this MRI and CT scan, and I found this kind of cervical myelopathy. And this is always a challenge for us if we want to do two different surgeries, if we want to do a big anterior approach, a big posterior approach, and we decided to do a circumferential approach. And for the circumferential approach, we decided to do a UB in C3, C4, and an anterior approach in C5 and C7. And this is the MRI and the CT scan 1 year after. Thanks a lot, Yuri. Unfortunately, I'm not with you, but for us, you're one of the bigger and biggest neurosurgeon and surgeon in UBE in the world. I'm very happy to be your friend. I hope I will meet you in Ukraine next year. And thanks to all the participants, and apologize not to be with you.
Thank you so much, my friend. It was excellent. We all appreciate your attending here. That's why I think what a lot of questions must be from the participants.
Yeah.
Not questions, but I have a very question. What about complication the first after surgery, and how long usually your patient stayed in hospital in case of 1 level, 2 level, or more than 3 level stenosis? Is it depend from the amount of the surgery or not? Thank you so much.
That's not depend of the multi-level or mono-level approach, but we have a learning. We had a learning curve with this kind of surgeries, and we saw some edema to the posterior cord after the first cases. But sometimes we just saw the edema on the MRI. Without symptoms, but sometimes we have some proprioceptive disorders between 2 and 4 months after surgery. And we decided to have a big reflection in the institute, and we changed a lot of parameters. First, the temperature of the water. We warm always the water. We use an endoscope with the water arriving on the side of the endoscope and not with the water arriving directly on the spinal cord. We always put a drain in cervical. That's not the case for the lumbar cases. And after there's different adjustments for the parameters, we obtain very good clinical outcomes with very less pain after surgery comparatively to the open surgery. Sometimes you can have, like for all the myelopathy, some neuropathic pain in one or two arms, but we have the impression less neuropathic pain after surgery. And the stay at the hospital, it's just 5 days. We do the first surgery on Wednesday, the second surgery on Friday, and on Sunday they leave the hospital.
Super. Thank you so much. Thank you so much for your presentation, for discussion, and we'd like to invite you at next year to take part in this congress in Chernivtsi city. It's also on west part of Ukraine. That's why we will wait for you. Thank you so much, my friend, and we will move to the next.
Thank you, my friend.
Thank you.
Thanks a lot.
Thanks
Have a
a
good
lot.
congress. Bye-bye.
Bye. See you soon. See you soon.
Bye-bye. See you soon.